Well, welcome to VU Christi Family Medicine. My name is Andrew Porter. I'm one of the Family Medicine and Sports Medicine faculty. And thank you, Dr. Anderson, for helping out with this, and Dr. Sumle. I'm going to be talking about doing a pre-participation physical examination. I'm going to primarily use the Kansas high school template, but it would be a similar template for middle school, college, and if you ever did some professional PPEs, they're going to have their own individual forms that you could follow and just go right down through that. So the first part of the PPE is going to be the history. The history is very important to make sure that the student athlete or the person that is going to be participating in the activity, that they actually fill the history portion out. Now it's okay if a parent goes through that with them, but they need to make sure that the student athlete is actually answering those questions. So the Kansas form incorporates all the 12 American Heart Association questions that they have asked us to inquire about. So those are all embedded within the form. So they're going to help screen for risky cardiovascular conditions that need to be screened for. It also is going to talk about nutritional status, past medical history, past surgical history, things like that are going to be important whether you're going to clear somebody to participate in athletics or not clear them. And the ultimate goal with this examination is to clear the person. You want people to be active. You want them to exercise, to get out there and move and just enjoy being active. Now, for those very few patients that should not be cleared because it's not safe for them to participate, this is what this is designed to do, is to catch those patients so that we screen them, find the ones that need further evaluation, do the further evaluation, and then hopefully be able to clear them from that standpoint. Or if we find something that's very serious, do an intervention and then hopefully get them back to activity or into activity after the intervention is performed. The two most common reasons people are not cleared for a PPE is, number one, is vision. They need to have a vision in one eye, the best corrected vision, so they can be wearing contacts for the examination, or they can be wearing glasses, but they have to participate in those glasses in the sport. They have to have at least one eye that has best corrected vision of 20/40. So that's the most common reason people are not cleared for this, is vision. And again, vision 20/40 in one eye. Second most common reason people aren't cleared is blood pressure. And what you really need to do is look at their height, their age, and where they're at in their systolic and diastolic blood pressure to correlate where that's going to be at percentile wise. And honestly, what I do, if I think somebody's kind of on the fence with that, I pull up my up-to-date calculator on those parameters. I stick it in to see what percentile they're at, to see if we can clear them or not based on that blood pressure. If they have a blood pressure that's elevated, that puts them in a category of not clearing, what I generally try to do in that standpoint is try and give them an opportunity to get cleared. Hey, let's have you go in to see the nurse, or go in to see your athletic trainer, or go into maybe a less intimidating environment. Get your blood pressure checked a few times in the next month to see what it is, after you've rested for a while and in a different environment, to see if we can't get that blood pressure into a zone where we can clear you. So make sure and go through the history. And then after you go through that with the student athlete, go ahead and start your physical. The physical form is going to have immunization status on that. They should have all that information when they got into school, and it should be able to be transferred onto the physical form. Next is going through their vital signs, their height, their weight, their blood pressure, their pulse, and their vision. Okay? And then I always calculate out the body mass index. That's a great way to start a conversation on, hey, your body mass index is low. It's less than 18.5. How's your nutritional status? And it's a great way to get into those other questions that you're going to need to ask as far as nutrition. Or let's say their body mass index is over 25 or over 30. Hey, I think it's awesome you're going out for sports. How can we help you to get into a healthier weight. One way is to clear them for the PPE if it's safe, get them exercising, and talk to them about nutrition. Next, looking at just their general appearance. Do they have a marfanoid type of appearance? And what I mean by that is looking at very specific things. There's lots of different stigmata or signs that patients will have if they have Marfan syndrome, but some specific ones that I like to look at is something called the thumb sign, where you have them put their thumb in and then roll their fingers over that. And a positive on this would be where Eric's thumb, his entire thumbnail is completely sticking out. And you can see for him it's not. And you can't have them like, you know, kind of like cheat on this. So like where he would like really try and roll his fingers over so that his thumb sticks out farther. Okay, that's called the thumb sign, or it's also called the Steinberg sign. The next sign is the Walker-Murdoch sign, or the wrist sign. What you do is you have them try and overlap their thumb over their pinky nail, and I usually have them go over the widest portion of their wrist. And a positive for that would be where his thumb completely overlaps his entire pinky nail, okay? And that is called the wrist sign or the Walker-Murdoch sign. The other ones that I like to do is see if he can fully extend his elbows, okay? And he can, so that's a negative. A positive in Marfan would be where he cannot fully extend past 170 degrees. So a positive would be where he basically gets stopped about right there. And that's because the tendons, the joints are so loose that really the limiting factor is the tensile, how tense the tendons are, and that's what blocks it from greater range of motion. The other signs that I look at for Marfans really quickly are to see if they have any pectus deformities, either a pectus excavatum or pectus carinatum, so whether their chest really caves in or caves out, okay? The other thing I do is I look at inside the mouth to see if he's got a really high arched palate. With Marfans, they have a very high arched palate. Next sign I look for is, let's have you turn your back towards the camera. Is I'll look to see if he has any skin striae, any major skin striae. And it would be, usually it's pretty noticeable if that's positive, where you've got a lot of striae. Next thing I do is I have him stand up and have you bend over and touch your toes, or get close. And I check for scoliosis while he's bending forward, and then have you come back up and check for scoliosis of the spine while he's standing straight up. Okay, and those are the main Marfan signs that I look for. You can do other ones. If one of those is positive, what I generally like to do is do a wingspan to height ratio. And to show you specifically how I do that, let's have you pop your shoes off. And what we would do is we would have him stand up against the wall. Okay, and I would mark off how tall he is. Okay, next thing I want you to do, Dr. Anderson, is with one hand on the ground, touch your fingertips to the ground, and the other hand get it as high up on the wall as you can. Okay, you can see that it's about an inch above his height. Okay, and in general, it's going to be like 3 inches to maybe even more inches above his height to be a positive wingspan to height ratio. If I'm really getting down to the nitty gritty and I need to know specifically, I'll go back to the height and weight station and have him do it actually on the height scale, and I can get really efficient numbers that way to see if it's more than 3 inches or more than 4 inches. Because a positive wingspan to height ratio of greater than 1.05 is positive. So if somebody has more than one MSK sign, I'll do the wingspan to height ratio. And then if they are having like 2 positive MSK signs, then you really need to look at further indications for Marfan's syndrome, whether you have them see an ophthalmologist to look at their lens, have them get an echo to look for aortic root dilatation, or get a lumbar spine MRI to look for dural ectasia, or a AP pelvis X-ray to look for protrusio acetabuli. There's lots of different things you can look at for Marfan syndrome, and those are all called the Ghent criteria, G-H-E-N-T, to help you decipher if they have Marfan syndrome or not. Okay, next, going down the list, we've looked at the body habitus. Next thing we're going to do is do an H-E-N-T exam. You guys know all how to do that. Why is it important? Why do I really need to look in their ears, Dr. Porter, if I'm doing a PPE? Well, what if they have a chronically ruptured tympanic membrane, okay? And they go down on the field, you go to look at them, and they've got that ruptured TM, but you don't know if that's chronic or not, okay? So it's important to look at the integrity of their tympanic membranes, look at the integrity of their eyes, make sure that their H-E-N-T exam is normal. Going down the list, we're going to look at lymph nodes. The major lymph nodes I like to look at is just like in the axillary region, along the neck, and maybe in the inguinal region to see if they have any lymphadenopathy. Next thing we're going to do is do a good cardiac exam. Now this is one piece of medicine where it is definitely different than just your run-of-the-mill cardiovascular exam. So what I like to do is I like to listen to the patient's heart while they're sitting. Okay, let's have you lay down on your back. While they're supine. Okay, now let's have you stand up, Dr. Anderson, and what I want you to do is squat down, but stay squatted down pretty much straight up and down. Try not to lean forward. And I have them try to not lean forward because I don't want his heart rubbing up against his chest wall. Good. Okay, now the reason why that's so important, the murmur in hypertrophic cardiomyopathy, the way that hypertrophic cardiomyopathy, and that's one of the main things that we're looking for on this PPE, because that's the most common cause of sudden cardiac death in patients less than 35, is hypertrophic cardiomyopathy in the United States of America, okay? The murmur in hypertrophic cardiomyopathy is a murmur that basically when that patient squats, what it does is it pushes that ventricular septum towards the septum, that ventricular wall towards the ventricular septum, and it creates this, the left ventricular outflow tract basically becomes larger when they squat down. And with hypertrophic cardiomyopathy, that left ventricular cavity is thickened, okay? And if that thickened cavity gets pushed in towards the ventricular septum, it creates a much better avenue for that blood to flow through systemically, and that murmur that they generally have, that systolic murmur, actually goes away or gets much fainter when they squat, okay? So often you'll hear a murmur with a fit student athlete when they're supine, because they're thin, they're very muscular, and that heart rubs up against the chest wall and you can hear a soft systolic murmur that's also short. And you might hear it when they're sitting, often you don't, but then when they squat, what you want to see is if that murmur goes away or if it stays, okay? And the murmur in hypertrophic cardiomyopathy will go away or become much fainter when they squat down. Okay, so that's the cardiac component. The other component of the PPE that's kind of unique is checking for coarctation of the aorta. So I'll have you lay down on your back. And to do this, I let them know, hey, I'm going to be feeling for your femoral artery in your groin region, so I don't want you to be alarmed. So I feel for the femoral artery. Okay? And once you find it, I compare it to the radial artery of that side, and they should beat at the same time. Okay? And then I do the same exact thing on the other side. And if they're beating at the same time, that's great. If they're not, it might be an indication for coarctation of the aorta. Okay, let's have you sit back up. I do a good lung exam. listen to the lungs on the posterior aspect and then on the apices anteriorly. And then I move into the abdominal exam. Now, be sure on your abdominal exam, you listen with both the bell and the diaphragm to listen for bowel sounds and also to listen for any bruits. You'll be amazed at how many bruits you find if you listen with the bell on the abdomen, and that might be indicative of renal artery stenosis, an abdominal aortic aneurysm, or something like that that you should be screening for on the PPE. Look at the skin. Do they have any signs or symptoms on the skin of herpes, gladiatorum, or any type of skin lesion that would preclude them from actively participating in sports? And then if you find something like that, you think your patient has herpes gladiatorum and they're a wrestler, you need to look at the guidelines on whether they have an active infection, if they've been treated for that, and how long do they need to wait to wrestle if they have herpes gladiatorum. The final thing that you do is a GU exam. We do not do a GU exam on females. As it sits currently, we do a GU exam on males to look for an inguinal hernia. Now that might change in the years to come, but as it sits right now, it is standard of care to still look for an inguinal hernia on the PPE. Now, I've had lots of 7th graders, 8th graders, where they are really nervous about that. They don't want to go through that. Use your own discretion at that point, whether just a good history and, kind of telling them about signs and symptoms to look for if you don't want to put them through that. But make sure and only document what you do. So if you didn't do a GU exam, just put deferred. Okay, the final thing on the general medical exam is a good neurological check. I check their cranial nerves 2 through 12, look for any focal neurological deficits, and then we move into the MSK portion. Okay, on the MSK portion, I like to look through range of motion, some strength testing, and some special testing to see if they are cleared to participate. So what I'll have you do, Eric, let's have you touch your chin to your chest. Good. And look back as far as you can. Okay. Look over to the right as far as you can. Over to the left. Okay. Good. We already had him do the thoracic and lumbar range of motion when he bent forward for the scoliotic test. Okay. Now I'm going to look at his shoulder range of motion. So what I'll have you do is come up like this. Good. And that's external rotation. And like this. Okay. Arms in front of you and come up as high as you can. Okay, good. That's flexion of the shoulders, and then out from the sides and touch at the top. And that's abduction. So he has full active range of motion in all those planes. I also like to look at the rotator cuff strength testing. So let's have you come up like this, and I will push down like this to check his supraspinatus. Let's have you lock your elbows in and push in. Good. And that's looking at subscapularis. Now push out, and that's looking at infraspinatus. Okay. Now there are hundreds of shoulder special tests that you could do. I do like to look at his shoulder to see for any labrum problems, and particularly if he's going to be doing any, throwing sports or any sports where he's going to be using his arm. And I usually only check it on the dominant side. What's your okay? So have you come across your body like this? Have you lift up towards the ceiling? Okay, and then rotate and lift up. And a positive on this would be where he had significant pain localized to deep within his shoulder that got better or completely went away when he gives you the thumbs up sign. Okay. Next thing we'll do is look at his elbow range of motion. Good. Have you flex up. Okay. And this is looking at supination. Have you come over, looking at pronation. So he's got full active range of motion in his elbows. While I've got him like this, let's check his wrist. In extension, and flexion, come out. Radial and ulnar deviation. Good. Now if he was, let's say he was a quarterback or a javelin thrower or a pitcher, I would check his integrity of his ulnar collateral ligament. The way that I do that is I do it at multiple angles. All collateral ligaments need to be tested at multiple angles to see if there's any laxity. Because sometimes at 0 degrees of flexion, there's no laxity, but when you flex it a little bit, maybe 15, 30 degrees, you feel a little bit of laxity. So check them at multiple angles. So I have them locked out here, and I do a valgus strain on that UCL to see if there's any laxity. Then I'll flex them up about 30 degrees, and I'll do the same thing there. A positive would be where you feel laxity and some pain. Okay. Next thing we'll do, we'll look at his lower extremities. Let's have you lay down on your back. And for this, what I like to do is check hip range of motion. So the way that you do that is you flex them up to 90 degrees, and you base range of motion in the hip based on which way the femur is pointing. So when I bend them in like this, that is going to be external rotation of the hip, and then internal rotation, and I do the same thing on the other side, okay? And then looking at knee range of motion, let's go ahead and have you bend your knees, bring your heels as close to your bottom as you can. Good, straighten back out. So looking at flexion and extension of the knees. Ankles, let's have you bring your ankles back as far as you can. Looking at dorsiflexion, point them forward, plantar flexion, and then I usually have him point them in and point them out, looking at internal and external rotation. Okay, just like the shoulder, there's hundreds of special tests to do, and you could do in the hip, the knee, the ankle. What I generally like to do in the hip is just to see the range of motion. It's a test called FADIR, F-A-D-I-R, flexion, adduction, internal rotation. So flexion, adduction, and internal rotation. And I basically will take him through that to see if it's nice and smooth in his hip, if he's got any clicks or pain deep within his anterior groin that could indicate that he has femoral acetabular impingement or a labral tear in his hip. Okay? Next, we'll move down to the knee. And I'll come over here. What I like to do for this is check his ACL integrity. So we'll do a Lockman's exam to look at his ACL. The other way that I test the ACL is with the anterior drawer. Okay? A positive would be where he has laxity. Next, we'll look at the integrity of his PCL, and it's a posterior drawer. And also the sag sign. A sag sign, what you look for there is if there's a sag down from the patella down to the tibia, that would indicate that the tibia is resting posteriorly from a PCL tear. Okay? Next, I like to do meniscal testing. So I have my thumb and my second and third finger in the joint lines, as medial and lateral joint line. And for this, it's a McMurray's test, so I'll flex him, internally and externally rotate that knee, and add some extension while I'm doing it too, to see if he's got any pain with that or any popping and clicking either in the medial or lateral joint line. Okay? The other common thing that I'll look for is to look for an effusion in the knee. And the way that I do that is I push over laterally to see if there's any volatile fluid in that superior lateral corner of the knee. And also do a Clark's sign. Clark's sign looks for patellofemoral pain syndrome. The way that you do a Clark's test is you provide a moderate roadblock for that patella, not like a concrete wall roadblock, but a moderate roadblock for that patella, and you have the patient contract their quad. Good. And go ahead and push down to the table, relax, and again push down. And what you feel for is if there's any crepitus underneath the patella, underneath the kneecap, and pain. A positive test would be where they have both crepitus and pain. Okay. Finally, we'll look at the ankle. The few main tests that I like to do with this is the anterior drawer. So I stabilize his lower leg, and I anteriorly bring his ankle forward to test the integrity of his anterior talofibular ligament, an anterior drawer, and then the talar tilt to test the integrity of the calcaneofibular ligament that rests laterally, and I basically invert his ankle like that to test for any laxity and or pain. I also perform a squeeze test where I squeeze his tibia and his fibula together, and a positive test is where it would shoot down the ankle and into the distal syndesmosis, where that could indicate a high ankle sprain. The final test that I do is where I dorsiflex and externally rotate the foot and push superiorly to try and either create pain along the lateral ankle or along the talar dome or in the distal syndesmosis, looking for different orthopedic conditions. Let's have you sit back up here. So these are with all MSK testing, I will say too, you need to ask where, if it hurts, where does it hurt? Because like I showed you on that O'Brien's test for the shoulder, a positive O'Brien's is pain deep within the shoulder. You know, it might hurt his back. Well, that's great, but it's not a positive test. It really has to correlate with, the test has to correlate with where the patient is having pain. So once I get done with my PPE, I look through all the tests to make sure I got them all done, and then hopefully you can clear that patient for participation. It's also good, a functional test is where you could have them duck walk. So let's have you stand up, and where Dr. Anderson would squat down and basically kind of waddle across the floor. That's a good, efficient way to look at range of motion and also look to check for muscle imbalances. You can do also a single leg hop test where you'd have them do it on each leg. And this brings us to the conclusion of our PPE. I look through all the paperwork, the history, make sure I've got it all completed. And then really the categories are they cleared for all sports without restriction? Are they cleared for all sports without restriction with recommendation for further evaluation or treatment for something? Or are they not cleared? And if they're not cleared, why? What do you need to have done? Let's say you hear that murmur that you think is indicative of hypertrophic cardiomyopathy, okay? And they have a family history of sudden cardiac death in their father who was 30 years old while he was exercising. Okay, that would get you concerned that they might have hypertrophic cardiomyopathy. What you'd want to do there is not clear them pending, further cardiovascular evaluation, probably a 2D echo, a stress test, stress echo, and then after you get that back, you could potentially go back, reevaluate the PPE, and then clear them for participation. With respect to the GU exam in males, it's important to check for an inguinal hernia, but it's also important to check for a testicular mass, if they have a varicocele or hydrocele, or maybe even a undescended testicle that would put them at a higher risk for testicular cancer.